Okay, so we're going to make a start with the final session of the conference and of the day. Thank you to those for coming back. This is a fantastic debate on the use of focused echo in heart failure. And we would like to firstly invite Ross Campbell up, who's going for four focused echo in heart failure. Ross is a senior clinical lecturer and honorary consultant cardiologist at the University of Glasgow, Queen Elizabeth University Hospital, Glasgow. He specialises in multimodality imaging and particularly in heart failure. So the floor's yours, Ross.
Thanks for the invitation, and thanks to Dan for the invitation. Thanks for having me. It's a pleasure to talk about things that you're actually interested in clinically, and I've got academic interest in these areas as well. So I'm going to propose that we can use focused echocardiography in heart failure, and I'll hopefully convince you that there's a time and a place. And I'll talk a wee bit about what I think is very much near future. I don't have any relevant disclosures for this talk. So as I mentioned, I'm going to talk about potential uses for focused echocardiography, and that's often synonymous with handheld, but it doesn't have to be. But I'll talk mostly about focused, and I'll mean handheld in that regard as well. So I think there's a real use in diagnosis, and I'll discuss why I think there's a need and where handheld and really focused echo might be of use. There's a device aspect to managing patients with heart failure. Who gets a device? When do you do that assessment? And something that I'm actually interested in as well, and I always talk about, is the assessment of congestion, and how myself and lots of cardiologists think they're better at this than they actually are. So focused ultrasound and echocardiography are very useful for that. So I want to talk about why there might be a need for using handheld or focused echocardiography in the diagnosis of heart failure. Why is it important? So NICE have very good and clear guidance on how to diagnose new suspected cases of heart failure in the community. And they actually use NT-proBNP, and that's something that I'll talk about that we use locally in the west of Scotland. And they suggest that patients with an NT-proBNP above 2,000 should get seen within 2 weeks. And I won't bother getting everyone to put hands up at the moment, but I suspect there's very few places around the United Kingdom that actually can deliver that kind of service. And certainly we've had a diagnostic pathway for heart failure for probably 20 years, and certainly we've had a very refined pathway which is like this, is modelled on this, and we try very hard to do this and can't do it. It's very, very difficult. And I'll really talk about why that's important. So there are consequences. So heart failure is a malignant condition. Untreated patients with heart failure have a worse prognosis than most cancers. And the time of when someone's diagnosed is also probably important. So there seems to be a trend where patients being their first diagnosis of heart failure appears to be happening in hospital. And that is associated, it's not caused, but it's an association that there's higher rates of mortality. So the first year time to mortality within the first year. So alive or dead at a year. If your diagnosis first happens in hospital, a third of patients will not be alive at a year. And that's very different from patients who are diagnosed in the community. So again, this is association, not causation, but I think that really what I try to do in my practice is to try and diagnose patients before they get admitted to hospital. And the reason for that is we've got fantastic treatments. So whenever I say to a patient about the diagnosis of heart failure, everyone thinks that it's their heart's failed, and that's that, and there's no treatments. But actually, I then go on and spend a lot of time saying, well, we've actually got these fantastic treatments, and the treatment of heart failure has been absolutely revolutionized. We have these 4 foundations or pillars of heart failure, and this has really been, frankly, a miracle of medical science, the improvement in prognosis that we've seen with these treatments. There's very few conditions that have had the same improvements in prognosis. So this slide just shows what treatment was like before these disease-modifying therapies came along. So I don't know if I've got a pointer somewhere, but On the left, the purple bar is the consensus trial, so that was the first ACE inhibitor trial, and that's the placebo arm, so 50% of patients were dead at a year. And you can see with each successive disease-modifying treatment, prognosis is dramatically improved. And actually, it's important timing, so even with low doses, starting an ACE inhibitor there'll be a treatment effect, so there'll be a reduction in the things that were measured in the trial, so the endpoints, so in this case, death, within 14 days, you start to get a treatment effect. With beta blockers, you start to get a treatment effect within a month. The curves start to separate. With MRAs, within 19 days, you'll get a reduction in cardiovascular death or heart failure hospitalization. The same can be said for sacubitril/valsartan, and also for dapagliflozin. Within a month, we'll get a clinically meaningful improvement with treatment. So time is very important. This is actually, frankly, it should be treated as a medical emergency in my mind, but it's not for some reason. So the sooner we start treatment, the better it is for patients. This is just, the slide shows what we do in Glasgow and Greater Glasgow and Clyde, which I think used to be one of the biggest health boards or trusts in the UK till Barts formed that mega trust thing that's now sees more patients than all of Scotland. But every patient with suspected heart failure gets an NT-proBNP, and then that's triaged and vetted by a consultant cardiologist with interest in heart failure, and then patients will go on and have an echocardiogram, which is then interpreted by a consultant. And there are bottlenecks throughout this, and this is quite an advanced diagnostic pathway, believe it or not. But the main bottleneck is around echocardiography. And like I said, we're trying to identify those patients that are the highest risk to do the echocardiogram very quickly, and we still struggle with that. And there are other factors about why we might want to employ another way of getting echocardiography done faster. If we look at United Kingdom, we zone in on Scotland. So, we're in Scotland's widely regarded second best city at the moment. But most of the people in Scotland live in the central belt, but we have this vast number of islands and this huge landmass, and a lot of patients find it very difficult to actually get to, a secondary care facility, for example, and they're disenfranchised by that. If it takes 2 days to actually get to your hospital appointment, that's something that perhaps moving the diagnosis into the community might be useful. With that in mind, we specifically looked at a question about whether artificial intelligence automated analysis of a handheld scan would be comparable with what we view to be the gold standard, which is an expert sonographer accredited by the BSE, of course, analysis of what in our manuscript we termed a CART scan, but basically a full echocardiogram. And what we did was actually got each patient with suspected heart failure who come up through our pathway was invited to participate, and they got a handheld scan, they got a full scan done by the same sonographer as part of a clinical pathway. We then analysed the handheld scans using an automated algorithm. We also analysed the full scan. And to compare whether these tests were equivalent, because that's what we're trying to prove, that the handheld scan was equivalent in terms of the results to the gold standard, what we did was we analysed the CART scan, which was the gold standard, twice. So we had the clinical analysis done, and then we had a core lab analysis done. And then we looked at the difference between these two. And then we compared the difference between the AI and each of these measurements. It's a bit of a complex endpoint, but basically it will be able to tell us using this individual equivalence coefficient whether they're equivalent to each other. So we looked at 866 patients with suspected heart failure. This was a typical cohort that we see with suspected heart failure. So elderly, obesity was common, atrial fibrillation was common, so not typical features for a good acoustic window. And when we had paired scans where there was an AI analysis and 2 human sonographer analyses of the CART scan, we found that the AI or the automated analysis was equivalent to the sonographer analysis. Not better, not worse, but equivalent. And the same when we applied that to the CART scan. This was an important metric to look at as well. How often did the algorithms produce an ejection fraction? And we've looked at other things other than just ejection fraction, but it is very important for these treatment decisions that I talked about earlier on. So in terms of the cart-based scan on the right-hand side, it was actually very comparable with the human analyses. And it was a higher proportion than I actually expected to see on the handheld scan, at 61%. Now, what's next for this? I think really, I was delighted to read this paper, this trial, because this really shows what I'm thinking next for this is to actually prove, can you actually implement some form of accelerated screening, not to eliminate the need for a full scan, because I don't think that is what we need to do, but actually to reduce that time to diagnostic echo to start treatment, because we know that a lot of these medications start having a treatment effect in days, and we know that it's actually, in my opinion, should be treated like an emergency, and we need to be treating patients as quickly as possible. So I think this is very near future, but we didn't test this in anger, so we didn't use the handheld scan instead of the full scan, but I do think that there's potential to use it as a way of accelerating, and also potentially to having patients have access to scans that are disenfranchised, areas of the community where they don't generally come up to secondary care, patients that are very remote, for example. So one area for focus scan, just briefly, I don't know what time we've got left. Okay. Wee bit of time? Yeah. So this is not near future, this is just now. So I talked about the disease-modifying pharmacotherapy for heart failure. So we also have fantastic device therapy, so implantable defibrillators and cardiac resynchronization therapy. And these have a class 1A indication in certain individuals. And that indication is if they have a bad ventricle despite optimal therapy. And it's based on ejection fraction primarily. There are other factors that need to be considered. But this is something where patients who have been diagnosed, treated, worked up for etiology, perhaps with multimodality imaging, I absolutely do not think they need an entire new and complete echocardiogram, 3 months, 6 months once they've completed their optimization. But we need a focused decision on, do they need an ICD? Or have they got, on the left-hand side of the panels, have they got ventricular recovery, which happens more and more multiple times a week at my clinic. I'm actually saying to patients, your heart's gone completely back to normal and we don't need any further tests. So I think this is very much a now, and this is how I use this. I don't see any major barriers. That doesn't have to be a handheld scan. That can be, specific lists run by sonographers, ideally incorporating physiologists into the heart failure team would be how I potentially see this happening. And just very briefly about congestion. So congestion, fluid overload, pulmonary peripheral edema, this is the primary reason for why patients get admitted to hospital with heart failure. Being admitted to hospital with heart failure is very bad for patients with heart failure. 1 in 10 patients still do not survive that admission. Very few conditions in medicine that actually can have a statistic like that. Identifying congestion is crucial in managing patients with heart failure. So whenever we're all assessing patients, clinically, a lot of us think we're better at picking up these different clinical signs than we actually are. I use focused echocardiography all the time. I'll look to see whether there's B-lines. So this is used a lot in research. I use it in research as well. It's good to objectify pulmonary congestion. I'm not suggesting that we actually have people counting B-lines, but if there's lots of B-lines, I think it can be reported. If there's pleural effusions or even liver congestion and distended IVC. These are very, very quick to do. I think they're very important, and actually I think it's another aspect that really we should be embracing, and where I think that my view on training in echocardiography, if we shouldn't have a halfway house and people should train to do echo, because to do a focus scan you have to be very experienced in my opinion. I do think that we could train the wider MDT to do this type of thing. So I think we could train our heart failure nurses to do this. I think all my heart failure nurses that work with me come up and say, I want to learn echo. And I say, well, that's fine. It'll take many years, but we can absolutely do that. But you should learn to learn echo the same way as our sonographers do. But I do think that this is a focused use of echocardiography that can be expanded to the other members of the MDT. And in the interest of time, I'll maybe wrap things up there.
Thank you very much. So thank you very much, Dr. Campbell. That was an excellent summary of the potential use for handheld devices in heart failure. So that's the 4 in our debate. And now it's a delight to welcome to the stage our president, who of course needs very little introduction. He's a consultant cardiologist, both in echo and cardiac MRI in Bath, co-author of various things, and general good egg. And here he is going to argue against the use of handheld devices in heart failure. Thanks, Dan.
Thank you, Liam. That was a great presentation, by the way, Ross. And so I've looked at this from a population type setting. So is there a role for focused handheld echo in the diagnosis, a new diagnosis of heart failure in a population type setting? So it's been a difficult week for me. So my car started playing up on Monday, horrible noise coming from the engine. Every time I turn the engine on, and I was on the phone to Ross earlier this week. I said, Ross, mate, my car is playing up. I don't know what I'm going to do. He said, Dan, I know the perfect mechanic. I know the garage for you to go to. Mention my name, Dan, and you'll get mates rates. He said, mates rates, Ross? He said, yes, Dan, mates rates. So off I popped to Campbell's Cars, and the mechanic came out. He had a look, and I said, look, turn the engine on. Turned the engine on, horrible noise. Got out the car. He said, your front 2 tyres are fine. Come back in 6 weeks and we'll do the rest of the service. It was an FGA, a focused garage assessment. So, you know, a lot of duplication here, and this essentially is what we're talking about these focused echo assessments in the community. I don't have any disclosures relevant to this particular presentation, but my only disclosure, I guess, is that I have a lot of respect for Ross as a heart failure cardiologist, and also as a primary investigator for echocardiography-based science, which is really hard to do, and so you've done that so well, so congratulations for everything you've done in terms of opera. So, in terms of focused handheld echo, is there a time and a place? I think there is, and I think we define that time and the place with level 1. I think it's very clear. If you have a critically unwell patient in front of you, there are 6 or 7 images that can answer a key question. Is there heart failure? Is there tamponade? Is there significant valve disease? If, on the other hand, we're asking somebody to do a focused echo to define heart failure to start medications for reduced ejection fraction, so that's the only question, is the ejection fraction less than 50%? If that's the only question, then we have to really be careful about the unknown, because what you don't know, you don't know. And so if there are focused echoes being done, we need our most senior echocardiographers to be doing them. But we can't afford to not have our senior echocardiographers giving patient-centered care in our communities or in our hospitals within the clinical environment. It's almost a waste to let them go and just do one thing, is the ejection fraction less than 50%, when they can be involved in so much more of the diagnostic spectrum that we have. And that's the key here. What are we missing? If the only question is the ejection fraction less than 50%, then we may be missing a lot. So all of these conditions that you've all come across many times can present like heart failure. So patients can have symptoms of heart failure and an elevated BNP and a normal ejection fraction. So that can happen with valve disease, with heart failure, with preserved ejection fraction, with inherited cardiac condition diagnoses like hypertrophic cardiomyopathy, with pericardial effusions, with pulmonary hypertension. You can have scenarios of heart failure type symptoms and elevated BNP with normal ejection fraction, so we will be missing a great deal of patients. The other thing that's really important is if you look at the community setting, 50% of patients with heart failure in the community setting will have heart failure with preserved ejection fraction. So we are doing them a disservice by not following them up, because there are now medications, SGLT2 inhibitors, that have come through that mean that we can start life-changing medications in 50% of these community heart failure patients. So what do the guidelines say? Well, the guidelines are pretty clear, nice guidelines, and these are the NHS England guidelines, which were updated in January 2024. So we should be doing an NT-proBNP, and guided by the NT-proBNP level, referring the patient for an echocardiogram and the key word here is and specialist assessment. Doing one without the other won't work. We do not have enough heart failure cardiologists to run this in the community. There are some parts of the country, such as Bath actually, where we don't have a community heart failure service. And so the notion that we can diagnose an ejection fraction and expect a GP to start and up-titrate medications quickly, I don't think is reasonable. What you'll hear from many people who are talking about targeted or focused echoes is that we need to do it. We need to get through the backlog. They can't just wait 6 months, and that's absolutely correct. They can't wait 6 months. But what will make it worse in the longer term is fragmenting a service so that they're having patchy diagnosis and treatments in the community. And this is the exact role for enhanced clinical triage. And this is the exact reason that we worked with the British Society of Heart Failure to come up with these triage criteria across the board. So the one thing we should be doing is that every echo request, primary care, community, in-sourcing providers, every echo request should be triaged. That is the way we're going to create space on our work list and prioritising the sickest patients. We probably also need to think about how we're structuring our through flow through the department. So if we have a backlog of 4 months, people are going to be waiting 4 months. So we then have to prioritise those who we clinically triage to have earlier echocardiograms. So we should have booked off slots each week. So we can, all of us can ask our heart failure team, how many patients with a BNP of over 2,000 are you seeing in the last month? They say 20. So every week you back off 3. It's less than 20, but you will prove that actually by slotting off these 3, the heart failure, the acute heart failure echoes will be done, and they will go to a heart failure cardiologist sooner. It's just shifting around an already long waiting list. So they are being prioritised, and that's probably appropriate with the way that we are with the NHS, and that's across the board, I think. There are several other factors when thinking about handheld echo versus a full echo, I'll call it, on the cart systems. The first is limited image quality of the handheld systems versus the cart. Operator dependency is huge. There are so many papers out there. You need your most experienced echocardiographers performing these scans. It cannot be done by people who aren't accredited. It cannot be done, I don't think, by heart failure nurses who want to do a 2 or 3 week course. Resources. If we start doing handheld echo to diagnose heart failure, it will only lead to duplication in secondary care. And governance and consent, sorry. So this is important, isn't it? So who is taking responsibility for the echocardiogram when something is missed? How are you consenting the patient, Mr. Smith, for having a third of an echocardiogram? And that needs to be looked into. We know that we're doing more echocardiograms, and this was from Keith's lecture yesterday, but we know that the demand's going up. And so despite us doing more, we need more of the workforce, and we do not have the numbers to be going into the community to be doing focused echocardiograms. We've had a lot of discussion over the conference about AI, and this image was from ChatGPT. Show me a pixie undertaking an ultrasound, and this came out. And we don't have magic pixies and magic fairies in the community doing our focus scans. And so what I think we need to do is keep it patient-centered and use the specialists that we have more of in our cardiology departments than consultant cardiologists or heart failure cardiologists. And these are our physiologists and our scientists to be embedded within the heart failure team. And this is the way we will slowly start, step by step, to improve things. So I absolutely do think we need some triage system in the community. It has to be point of care. NT-proBNP and symptoms is a great starting point, and that's been well validated through thousands of papers. So this is what happens at the moment. You have a high NT-proBNP, you're referred through to secondary care for an echocardiogram and heart failure service. So that includes a consultant, a nurse, and a pharmacist. Actually, we need to bring the physiologist centrally into this team. So we need to do the point of care NT-proBNP, and then empower the physiologist to do these advanced roles in heart failure clinics. The physiologist will then lead into the heart failure service. This is a two-way connection, the heart failure service referring patients to the physiologist for continuity, and the physiologist referring into and being part of the heart failure service for that new patient initiation of therapy. This could easily bring about rapid access heart failure clinics acutely. You'll be seeing HFrEF and HFpEF patients. You're not just going to discriminate based on a number of 50%, which is what we seem to be doing. And it allows that follow-up continuity to be in place where they're seeing the same person, which is so important, and that doesn't happen in clinics, unfortunately. Importantly, our physiologists who are training to level 3, this new standard, will see other disease pathologies on echo that they're already used to. They'll see heart valve disease, they'll see inherited cardiac conditions, they'll see ECGs, arrhythmia, AF, and all of these patients can then be referred through to the appropriate team. And whilst we're developing this, we always keep an eye on artificial intelligence, and so we insert the appropriate artificial intelligence along the right section of the patient pathway. So that might be at the top, at point of care. ECG AI is evolving rapidly. There are such good electronic stethoscopes which can tell, pretty accurately about murmurs. And then in the clinic itself, we can speed up our reporting time, measurements, reporting, and eventually we'll get to the place where the actual AI system will be able to phenotype the type of heart failure and the prognosis, so that we can go back to Dr. Campbell's clinic and say, look, this prognosis is poor, can you see them earlier? And that is what will happen, and that's what we're going to embrace, and that's what you will all be a massive part of. So, in my opinion, focused handheld echo has no role for the diagnosis of heart failure in the community. Thank you.
Wonderful. Okay, thank you, Dan, and thank you to both speakers for making their cases so clear and clear and eloquent. It's a hugely important topic and has significant implications for patient care and workforce delivery. So we are going to take a vote. It's important we get a result here. So I can't see very well. Can you see?
Not at all.
Okay. Can we have a show of hands, please, for those who think that Ross is going to win this debate? Ooh. Ooh.
1.
I get 2. 2.
They're all 3. We'll give you 3, Ross.
We could wait a little bit longer, but clearly, let's just have a show of hands for Dan.
I think it's close.
Very close. Okay. It's a wonderful debate. Thank you very much. It is really important, and these debates are crucial in terms of bringing around topics and making it available to people and to delegates. So thank you to the speakers.